Hi, in this lecture, we are going to look at the factors that control blood pressure. Now, we have been actually talking about this over the last several weeks as we've been learning about blood and the heart. We did talk about things such as blood volume, and remember that when we look at blood, blood is made up of plasma, and plasma is about 90% water. So we know that our kidneys are going to be really important because they control how much water is lost from our blood, also what we take in. So our blood volume is a factor for our blood pressure. We talked all about the heart. We talked about cardiac output, and remember that cardiac output was a direct factor for blood pressure. So we use this little directly proportional symbol. So we know that cardiac output is a factor of stroke volume and heart rate, and those control blood pressure. And in our last lecture, we looked at resistance to flow. And we know that if there's more resistance to flow, that also affects blood pressure because the heart has to work harder and overcome that pressure. Or I should say to overcome all of that resistance. So we know blood pressure is critical. It's literally the force pushing blood to our organs. If our organs don't receive blood, then they become hypoxic and we'll have organ failure. When we look at blood pressure, there's two main types of controls. There's what's called the neural, which is the short-term regulation, and then there's the hormonal, which is also known as the long-term regulation. So short term just means that it's quicker to respond. And so we look at some of our short term, a lot of this are going to be those reflexes that you've already learned. We talked about the cardiac output reflex when we looked at those baroreceptors and chemoreceptors. Remember that they could control heart rate. They could send information up to the medulla oblongata and quickly change heart rate in order to change blood pressure. We know that we have things that can change contractility of our heart. The contractility, remember, was the muscle contractions, and that we know that if that were to increase, we could increase our stroke volume. We also know that we can change our blood vessel diameters very quickly, and that if we change the diameter, that will change the resistance and then the pressure. So these are quicker types of controls. Long-term are called long-term because they're mainly done through hormones, and they're going to be really affecting the blood volume. So when we looked at the blood volume, remember the blood volume is the amount of blood in your pipe. And so we know if we have a higher blood volume, we have a higher blood pressure, and if our blood volume decreases, then our blood pressure should decrease as well. Well, those involve usually the kidneys and some sort of change to blood volume, so they take a little bit longer. The first thing we're going to look at right now is a neural short-term control over blood pressure. Now, you've already learned reflexes. You've already learned the baroreceptor and chemoreceptor reflex and how they affect heart rate. We have one more center we have to look at, and we're going to put them all together. So in addition to the cardiac centers, right, the cardioacceleratory and cardioinhibitory centers in the medulla, there's one more center. It's called the vasomotor center. And this center is going to primarily release norepinephrine. And it sends this out to the blood vessels, mostly arterioles, but out to the blood vessels of the body. And so the vasomotor center is going to control norepinephrine, and it's going to regulate the vasodilation and vasoconstriction, right, the opening and closing of those blood vessels. So this one only releases norepinephrine. There's just one center. When norepinephrine is released, it binds to an alpha-1 receptor in smooth muscle. When it binds to the alpha-1 muscle in the smooth muscle of the arteriole, it opens calcium channels. Calcium enters, and when calcium enters muscle, you might remember it contracts, and in this case, it's going to vasoconstrict. Now, there's one little exception here. Only in skeletal muscle and the brain. So the arterioles that are bringing blood to your skeletal muscles and your brain, this center triggers the release of NO, which is nitric oxide, because nitric oxide is a vasodilator. And anytime you're trying to raise your blood pressure or increase blood flow, you're not going to want to ever constrict blood vessels to your brain, right? If you constrict blood vessels to your brain, you're going to pass out. You're decreasing oxygen supply. And typically, if we're trying to change blood pressure, we're trying to maintain flow to muscles. So only for these two areas, the vasomotor center releases nitric oxide. So we only have one center. We have a vasomotor center. We don't have an acceleratory or inhibitory. So what happens is, you learned before that the arterioles have a vasomotor tone. So they're always getting hit with norepinephrine, always. So they're partially constricted already. So what the center does is it either increases the amount of norepinephrine, so it constricts more, or it backs off the norepinephrine, so it opens up. So I like to think of this like a dimmer switch. The switch is always on, always releasing norepinephrine. We can increase the norepinephrine and constrict more, just like on a light switch, or we can pull the dimmer switch down, we can back off, and we can dilate. So if my blood pressure should fall, if it's too low, the way this center fixes it is then I'm going to increase the release of norepinephrine and I'm going to vasoconstrict more. If, however, my blood pressure is too high, this center will respond by backing off of norepinephrine on those vessels to kind of open them up and let them relax. So we're still doing the baroreceptor reflex. Not really a good place to put my head here. The baroreceptors, we know, monitor stretch. We know they're located in the carotid sinus and the aortic arch. That's the exact same thing you've already learned. They use the same nerves to carry information up to the medulla. So the nerve from the carotid sinus is cranial nerve 9, and the one from the aortic arch is 10. It's all the same. And same thing, they're responding to stretch. So they're going to pick up if there's increased stretch. And since blood pressure depends on cardiac output, we already talked about how these centers relay information up and that either the cardioacceleratory or the cardioinhibitory centers are going to respond. But now we're going to do the full picture. So what really happens is if there's a change in blood pressure, those baroreceptors are going to send information up to the medulla, but they send it to both the vasomotor center and the cardiac center. So these centers are going to respond together. So if blood pressure went up, then what's going to happen is we need to lower blood pressure. So what we would need to do is lower our heart rate, and then the vasomotor, remember, controls the vasodilation or vasoconstriction. So then if we want to lower BP, we need to vasodilate those arterioles. So we're going to be looking at our cardioinhibitory center, right? So we're going to come back to the vagus nerve is going to go to the heart, right? It's going to go to the SA node. And when it goes to the SA node, it's going to release acetylcholine. That binds to your muscarinic receptors. Remember, it hyperpolarizes, so it slows down the heart rate. So if we decrease the heart rate, we decrease the cardiac output and we decrease the blood pressure. But at the exact same time, the vasomotor center is sending information out to your blood vessels and it's backing off. It's letting your blood vessels vasodilate. So now, if I want to know the baroreceptor controlled blood pressure, you have to tell me both. It's the vasomotor and the corresponding cardiac center. So if blood pressure decreased, what would happen now? Well, we know if blood pressure went up, or excuse me, let me back up, sorry. If blood pressure drops, same thing, baroreceptors are active because there's less stretch, and they're going to send information up to the medulla. So now the vasomotor center is going to increase release of norepinephrine. When it's activated, it's going to cause vasoconstriction to raise pressure, and at the same time, it will release NO to the blood vessels we said in your brain and your skeletal muscle. Now, if we're looking at cardiac centers, if blood pressure dropped, now we're going to look at the cardioacceleratory center is going to respond. And remember that the cardioacceleratory center is going to release norepinephrine. It's going to go to the SA node. When it gets to the SA node, this time it binds to beta-1 receptors. So remember, when we're looking at smooth muscle, it's an alpha-1. When we're looking at cardiac muscle, it's a beta-1. And now it's going to open the sodium and calcium channels. So I'll try to fit this on the screen. We know that when it went to the blood vessels, and bound to an alpha 1 at open calcium channels. That's why we have the vasoconstriction. And when we're at the heart with the beta 1, that's what's going to raise our heart rate. So if our heart rate goes up, our cardiac output goes up, and our blood pressure goes up. Now remember, this is how we raise blood pressure. So we're going to come back to those chemoreceptors in just a second because they're also involved with this phase. Before we do that though, you may have heard of something called a Valsalva maneuver. So when you defecate and you like bear down, or if you're lifting really heavy weights, there's a brief period where you close off and you're just, you know, basically you're closing off your pharynx, your mouth and nose, and you're basically exhaling. So it causes a big increase of pressure inside your chest. Your intrathoracic pressure goes up, and that can compress your aorta and your vena cava. So there's a couple things with this maneuver. Sometimes in some individuals, it can cause a dangerous drop in venous return, which would drop your blood pressure and cardiac output, and it can make you drop. It can make you pass out because there's a drop in cardiac output to your brain. In some individuals, it could trigger cardiac arrest, usually people who already have issues with their heart. So sometimes you'll hear about somebody, paramedics come in and they find the person on the toilet. Another thing though is when you do that, it actually activates your vagus nerve. So it is a technique that's used as well to lower your heart rate. So if you tend to have like tachycardia and fast rhythms, the Valsalva maneuver stimulates the vagal tone. Also that carotid massage I mentioned can do it, and vigorous coughing. So these are all things that might be used clinically to try to slow down your heart rate. So let's come back to the chemoreceptors. Remember, they're a little bit different. They're in the same place. They're right next door to the baroreceptors, but they're a little more specific as far as what they respond to. So they're looking at your CO2, your pH, and your O2 levels in your blood. But remember, they're specifically triggered if your blood O2 or pH decrease or your CO2 goes up. So they have a one way of working, right? So O2 pH drops, CO2 goes up. Their job is to become excited and try to increase your blood pressure, because if those things are happening, you need to get blood to your lungs faster. So your vasomotor center is going to be more active, and you're going to release more norepinephrine to that alpha 1 receptor and cause more vasoconstriction. And if we're looking at the cardiac center, as we said earlier, we're going to be looking at the cardioacceleratory center. We want to raise heart rate. So this time norepinephrine goes to the SA node. And when it gets there, we already just showed this, it binds to the beta 1. So understand that you have a baroreceptor and a chemoreceptor reflex, and they both involve both centers. So this is another diagram. It might be helpful to you to put it all together. So you again can see the green and the yellow. The chemoreceptors are yellow, the baroreceptors are green. We already know where they are. We know that relaying information from the aortic arch comes up through the vagus nerve, and we know that the glossopharyngeal nerve is also important for bringing that sensory information in, because it's a reflex, right? You have information coming in. This is your processing center. So there's technically 3. There's one cardiac and one vasomotor, but there's 2 of those little centers inside the cardiac. Then we have to have the response, and the response comes out through norepinephrine, right? If we're looking at going to our arterioles, or if we're coming from a cardiac center, we use the cardiac nerve and the vagus nerve to go to the SA node. So it's identical. The part on the heart you've already done. All I'm doing is adding the little piece here from the vasomotor center. Now, long-term control, we're really looking at hormones, because hormones are primarily going to affect blood volume. However, some hormones can do short-term control as well. So we have both coming back. What you're seeing on this screen is more of an example of long-term control, because we're looking at some hormones that affect urine output. So you would have learned the renin, and you have a chart in your book, a little table in your notes. We're not filling that out yet. Let's just look here, and then we'll go to the table. So in AMP1, you learned about, it's called angiotensin or angiotensinogen. So let me back up one second. Angiotensinogen is made by the liver. That is a big protein. The enzyme renin is going to break that down into angiotensin 1. Angiotensin 1 travels through your blood, and then it gets converted to angiotensin 2 by an enzyme called ACE. And ACE is angiotensin converting enzyme, and you might remember that happens in the lungs. When we get angiotensin 2, that does several things. One, it directly causes vasoconstriction. It's a very powerful vasoconstrictor, but it also triggers two hormones, ADH and aldosterone. Now, these hormones both go to your kidney. They go to the nephron. ADH causes the reabsorption of water. You might remember learning about the aquaporins. So water is reabsorbed. What that means is it leaves what's called the filtrate. The filtrate is what's in your kidney before it becomes urine, and it goes into your blood. So it's going to increase your blood volume. Well, aldosterone does the same thing, just a slightly different mechanism. What aldosterone does is it goes same thing into the kidney, into the nephron, but it causes the nephron to reabsorb sodium, and then water tends to follow sodium. So it primarily affects sodium and water tags along. So it also is going to increase your blood volume. This is another picture. This is probably what I used when I taught it to you before in A&P1. So you get angiotensinogen or angiotensin from the liver. It's going to be converted by the enzyme renin into angiotensin 1. That travels to your lungs. When it gets to your lungs, ACE, the enzyme ACE, is going to convert it into angiotensin 2, which is the active form. Then we have angiotensin 2. It directly vasoconstricts blood vessels, and it affects other hormones. Now, let's go to this chart now, and let's try to fill this in, because some of this you've already learned. So if you're looking at the hormones, you have the adrenal medulla hormones. So remember, these are always released anytime your fight or flight kicks in. So this is my epi and norepi. Now, when I'm using epi, and I realize it's a little messy, epinephrine or norepinephrine are both released from the adrenal medulla, and they have a short-term action. They do a couple things. In fact, one thing we know they do is they increase heart rate, right? So they directly increase heart rate. They also increase contractility. Remember that from the heart lecture? They had a positive inotropic action, and we know that norepinephrine directly increases blood pressure by vasoconstricting. So these are really important hormones. They're very good at affecting blood pressure, and they do it very quickly with this short-term control. Now, thyroid gland, I'm going to try to type because I realize my handwriting is pretty bad. So we have T4 and T3 are the hormones from the thyroid gland, and these hormones mechanism tends to be more short-term because these hormones mimic epi and norepi, and they're particularly good at increasing heart rate, and they increase contractility. They were an example of a positive inotropic effect on the heart. So I was trying to type and talk at the same time. So these are thyroid hormones. Now, we already mentioned ADH. Do you remember where it comes from? It comes from the posterior pituitary. Now, as far as what it does, we just talked about it, and we said that it's going to go to your kidney, go to your nephron, and it's going to open these aquaporins to increase reabsorption of water. So what that means is more water goes back into your blood. And so this is going to increase your blood volume. And if we increase blood volume, we increase blood pressure. Now, the renin-angiotensin system we just went over. We said angiotensinogen came from the liver. We said that the conversion of angiotensin 1 to angiotensin 2 required ACE. And the enzyme renin started it off with the angiotensinogen to the angiotensin 1. So when we're looking at angiotensin 2, as far as site of release, renin comes from the kidney. Angiotensinogen comes from the liver, and ACE is in the lung. So you got a whole bunch of things. But we do know, however, that angiotensin 2 is a vasoconstrictor. So that's more short term. That's a quicker response. But then we also know that angiotensin 2 triggers the release of aldosterone and ADH. And so we know aldosterone is going to increase your blood volume because it basically, actually, let's do it this way. Sorry, I realize it's a little messy. So I wrote a little bit here. We know aldosterone is going to increase sodium reabsorption, which will then increase water reabsorption to increase our blood volume. And then ANF comes from the atria of the heart. So ANF comes from the heart, and it's the opposite. It's an antagonist to aldosterone, so it decreases the reabsorption of sodium. Well, if you reabsorb less sodium, that means that you eliminate more in your urine. So it increases the sodium in your urine, which means water follows. So now what we would say is that we are increasing our urine output. We're urinating more, so that will lower our blood volume and lower our blood pressure. Whereas ADH and aldosterone are decreasing our urine output, right? That's how much you pee. So if you're urinating less, then what that is going to do is cause you to hold on to the water, because where does the water go if you don't pee it out? Well, it stays in your blood. So this is the end of our lecture as far as the regulation of blood pressure. The next lecture, I'm going to go over kind of all this one more time to kind of put it all together in one package for you.